Don't fill it out. All right, over to you, Anna, to talk about another event we have coming this fall.
We are excited to share that we'll be opening registration on July 15th for our in-person conference in November, which will be in our hometown, Boston, Massachusetts. This is our 12th annual conference, and our theme this year is Envisioning Our Future, Growth and Innovation in AD. It will be held on November 14th and 15th, and you can attend in person or virtually. Mark your calendars to register on July 15th.
All right. As many of you know from yesterday, but quick refresh, all of this good stuff is recorded. So if you miss anything or you just love the dulcet tones of folks' voices and want to hear them over and again, you can go to the Summit Hub. The only thing that isn't recorded are the breakout sessions, but you can have access to the breakout session slides and any related worksheet content. So if you didn't get to go to a certain breakout, you can still access some of those materials. Anshul is dropping links like it's hot in the chat box. So those are all there for you. And if you miss any links, we'll make sure you get them all at the end of the day for your farewell email from all of us. All right, quick housekeeping. Over to you, Anna.
All right, this may be a refresh for those who were here with us yesterday, but please turn your video on. This is an interactive event. Please do turn your videos on for your workshops as well. We want to be hands-on learning in those. We'd like to see all of your beautiful faces and connect with all of you. If you don't consent to having your image on our pictures or videos, please keep your video off. Please use the chat box. We had stuff flying around in the chat yesterday, reflections, links. Continue to do that today. We encourage you to use that feature on Zoom. Please make sure your Zoom name is correct and has pronouns listed if you're comfortable. We want to ensure that we are referring to you the way you would like us to. After the summit, we will send an attendee contact list and add you to our mailing list. You can always opt out. Just reach out to Anshul by end of day to do that. And if any technical issues come up over the next 2 days, please direct message Anshul to help you out.
And further to the video piece, we know y'all are experiencing, and we may all continuously experience this for the rest of time, burnout from being on screen, right? It's not fun. We don't love being on screen. Some of us do, some of us don't. If you need to shut your screen off to take care of yourself for a bit, please do. And we do appreciate, when you can show up, especially during those breakouts that folks can see each other's faces. We know it's not possible all of the time, but again, we thank you for being here in as much of a capacity as you can. All right, so for those of you who want to ask questions, pop those links in the chat from an article you read that is connected to the conversation, or just to connect with somebody directly. Please do send direct or group messages in the chat box. If you have a question for a speaker, drop it anytime and we will stay on top of it as much as we can. And if we missed anything, we will make sure that we follow up as best we can. Case in point, we have some leftovers from yesterday. We realized just this morning when we put this slide together that sushi is probably the worst kind of leftover you can have. So let's pretend this sushi is fresh. And we will be just following up briefly for a few moments on a question about community ownership of data, the connection there to data walks, which we touched on ever so briefly yesterday, and the New England Journal of Medicine article that Mike talked about yesterday in relation to his think tank equitable data sourcing presentation. So Anna, over to you to refresh us on a question that we did not get to yesterday.
Yes, at the end of the day, we had a question from Carla Foster. She asked, how do we begin to think about creating environments that allow for community ownership of data? And I want to just start off by level setting on what community ownership of data is. So this is when data are owned and controlled by the community from which they were collected. And communities have the ability to participate in the collection of that data, the use of that data, and the sharing of that data. It can be especially important for communities that have experienced harm from participating in research in the past and marginalized communities. And one way that we can ensure that community ownership of data is happening is through data walks. And Bevan's going to walk you through a data walk.
We're going to walk the walk about the walk. So data walks We found an amazing guide between last night and today from, again, we love the Urban Institute. We are going to drop all this good stuff in the chat box. But this is based on a guide that was co-created with the Metropolitan Housing and Communities Policy Center, and walks through all of the different steps to building a data walk. How do you do more than just share data with the community and get them to nod and smile and maybe ask a few questions, and have instead them engage with the data? And again, thinking about how do you build this in a way where, literacy levels are respected, where communication is clear and is adapted to the specific audiences with whom you're speaking within that community. Here's a couple quick screenshots, and you can go ahead and check out more at the link that Anshul just dropped in the chat box. So there's everything in this, from designing a data walk to how to connect more with community members. Anna will talk a little bit more about these next two slides now.
So data walks take a lot of thoughtful planning. This isn't something you can just do on the fly. I want to talk about and highlight the first step and the last step. So you can find out more about the steps in between in the link that Anshul dropped in the chat. But you first want to ask the right questions to figure out what your goals are and what you want to learn from the data walk. So think about if you want to gain a better understanding of quantitative data that already exists, or empower community stakeholders to buy in on a specific issue, or if you want to pair the data with interviews and focus groups to get even richer data. And then the last step is connecting with community members. So you'll want to begin your data walk event by starting with discussion questions for those attending the walk. So the idea is community members walk around different stations and look at posters and reflect on the data. And before they do that, you'll want to ask them to think about discussion questions as they're looking at the data in front of them. So there are some examples on the slide here of these questions. While you walk around and look at the posters, ask yourself, what surprises you about the information? What is the good news? What is the bad news? If anyone's done a data walk before, I'd love to hear about it in the chat box. So if you've done a data walk, pop that into the chat. I personally have not. Bevan, I know you mentioned that you have seen one or been part of one. So really, really cool stuff. And I would highly encourage you to look at the link that Anshul popped in the chat with the report that walks through every single step of doing a data walk.
I think this is just such a cool thing to start thinking about. It's not always in the, day-to-day vernacular. And Elizabeth Fallimach from Maine asked a great question. I wonder about a virtual data walk. Hey, that's something that could work too, especially if you have communities who may not be able to get to a location either via transportation or not being physically able. You may want to think about how can you bring a data walk to a community versus having them adapt themselves to what you want them to do, right? So lots of good questions. I'm sure there's some data on that we can take a peek at. Further to what we were talking about yesterday at the end of a long and juicy day, Mike mentioned this NEJM article, Hidden in Plain Sight, Reconsidering the Use of Race Correction in Clinical Algorithms. We got to take a peek at this. We didn't read it cover to cover, but we encourage all of you to do that. We will be doing that in the post-summit afterglow. But we will drop this. Oh, sorry, we did just drop this into the chat box. Anshul is on fire. And there's a table here that walks through so many different areas of clinical specialty, nephrology, obstetrics, cardiology, and so forth, and breaks down, the different input variables and how folks can reconsider what race correction has looked like and really kind of challenge their conceptions and perceptions of whether those corrections need to be changed, need to be challenged, need to be updated, need to be there at all. Again, as mentioned throughout this summit, these are not easy questions with simple answers, but I really think for all of us who are info hungry, which if you're in detailing, you're info hungry and you love to share the info. Keep up with, all of these different conversations as much as you can. ask us to hold events that provide space for specific areas of sub concentration, sub exploration. We will be doing that anyway, but we also need to know what you need to know. So if we hold something in the future, like a community check-in where we just start skimming the surface and you think, you know what, Anna, Bevan, Mike, Anshul, we really need something in this direction. It would be really great to have an ongoing learning group about why. Please let us know. We really want to meet your needs versus think we know what they could be and be a little bit off base. So all right, that was a lot for the morning, but we wanted to make sure that we, dot all our I's and cross all our T's. Quick refresher on what you can expect for today, the final day of the event. Anna, what do we got?
As a review, we're going to be talking about the patient experience. We're going to be talking about implicit biases, AD adaptations, building confidence, and infectious diseases.
We'll be making sure that everything we talk about considers, what health disparities have arisen within that specific clinical topic or area. We're going to have a spotlight on gender affirming and gender expansive care, which we're very excited about for this afternoon. Again, talking about how to break clinical silos, build community partnerships, encourage clinicians to do that as well with our support as a detailing community, and continuing to think about equitable data. And as always, your continued contributions are critical. We're going to have a lot of fun this afternoon. Anna will tell you a little bit more about what we're all going to create together. But in the meantime, here are our workshops for this morning, right after our warm up right now. So excited to offer a new workshop that Anna and I created together based on folks coming to us and saying they needed some more support in feeling confident about walking in the door, meeting with a clinician, saying what they need to say. So please join us for Own Your Space, Building Confidence and Embracing Your Unique Skill Set. If you feel like you can do academic detailing with your chin up and your cape on, this might not be the right class for you, but you're still welcome to join and cheer other folks on. Anna, what else do we have today?
We have cultivating commitment, strategies for achieving leadership buy-in. This is for new or experienced detailers or program managers about gaining buy-in from leadership. This session will be facilitated by Christine Fishman and Vishal Kinkabwala. It is due to be a very energetic session, and I would highly recommend attending that.
All right. And if you're thinking about community synergy, the ways in which you can connect the dots between different community groups and also encourage clinicians to be thinking about health disparities outside of just what they think they're able to do in their own clinics, this is definitely the workshop for you. Jenny Waugh and Alicia Heil will be leading this. Great session. We had a lot of fun watching them put their brains together and build something awesome for you. So please do attend the one that feels most compelling for you, but know that the other ones, we do have those slides ready to go. All right, so really quickly on the menu today, again, we want interactivity to be front and center. You're the leaders, we want your solutions. We hope that you'll be walking away with tangible resources at the end of each workshop. We do co-create something with you and then get it up on our Summit Hub site. So there are more and more resources that you had your hands on and are a part of. And of course, you'll get a chance to network and learn from each other. Really briefly, you can always get the AD Summit program book based on, it's a really gorgeous book. We wish we could have printed it, but we're saving trees and being virtual. Thank you to Anshul for putting together something so stunning. Anna's going to walk us through what we're doing today.
All right, in just a moment, we'll head into our program development workshops that we just walked you through. We also have a best practices spotlight with one presentation on detailing for gender affirming care and looking beyond the binary. We have another presentation from the New York City Department of Health and Mental Hygiene, and we'll get to take a deep dive into one of their famous action kits. We're going to wrap up the event with a community roundtable where we will pick your brain on how we can build inclusive detailing campaigns from start to finish. So we have a very exciting afternoon, really excited to get into things. So with that, we have a quick chat waterfall and then we'll go into our workshops.
All right. What's the mood, everyone? What's the current mood that you are in this moment? Feel free to share whatever feels good for you. All right. Excitement. Thanks, Caroline. Carolyn, rather. Excited as well. Motivated, ready to learn, ready to seize the day. Scrum-diddly-yumptious. We have a Roald Dahl fan in the crowd. Inspired, relaxed, alert, chipper, motivated, mellow, more excitement, hopeful, bring it, shiny and happy, motivated, relaxed, excited, and relaxed. Hey, that's all we can hope for. A little bit of excitement, a little bit of relaxation. We hope to get right into that sweet spot as we prepare to go into workshops. We realize we ate about 4 minutes up of workshops. So workshop leaders, we apologize, but we are going to try to stay right on time and end at 1:30 Eastern. Please grab your link to your workshop from the chat box. If you're still not sure which one to join, take a quick gander at narcad.org/breakouts for descriptions, and we will see you in there. Thanks, guys.
See ya. We are going to head into our next session. I hope you all enjoyed your workshop sessions and had some time to relax during your break or catch up on work, whatever you chose to do. I hope that you are back in this space with us now and ready to finish up the summit. So we have 2 special presentations out of Arizona and New York City. I am thrilled to be able to introduce our colleagues Ryan Anderson, Nina Shabat, and Wendy Agrone. Ryan is our first presenter. He's an academic detailer for DISH Arizona. They're the Detailing for Improved Sexual Health in Arizona. Ryan has 14 years of experience volunteering with organizations that serve the LGBTQ+ community. Ryan is passionate about improving health outcomes through academic detailing for those that need it most. Our second presentation will feature Nina and Wendy from the New York City Department of Health and Mental Hygiene. Nina is the evaluator for the Public Health Detailing Program in New York City. She leads the planning and execution of all evaluation and monitoring activities for the program, including survey instrument design and internal and external reporting. Wendy has been with the NYC Department of Health and Mental Hygiene for over 15 years and currently works as an outreach representative for the Public Health Detailing Program. She has extensive experience working in various New York City communities. Wendy has conducted community needs assessments and has done extensive work with new mothers in the city. It is my pleasure to turn it over to Ryan for our first presentation to share about his work in Arizona beyond the binary. Ryan, over to you.
Thank you so much. And thank you all for being here today. So we're going to take a look at innovating academic detailing for gender expansive care. So I don't have any conflicts of interest to disclose.
All right, Ryan. We have a chat waterfall. You read the question, and I am not an expert in mythical creatures, so I'll let you read the chat box if you have it open.
Sounds good. All right. So if you could be any mythical creature, what would it be? So mythical creatures can include things like dragons, fairies, gnomes, gargoyles, things like that. Awesome. I'm seeing Bigfoot, Loch Ness, mermaid, centaur, banshee. I have not heard banshee yet. That's really exciting. Medusa, phoenix, unicorn. Yes. A witch. I love it. I would definitely be a dragon. If I could breathe fire and fly, like, why not? So I do want to ask folks, kind of keep your answer in your mind. We are going to be circling back to this question in a little bit. All right, so I am on the DISH AZ team, and like what Anna was saying before, It is detailing for improved sexual health. We focus on connecting, educating, and supporting. With I do like to mention with the education piece, it is very much a give and a take. We learn just as much, if not more, from our AD clients. And I do encourage folks in their work to keep that in mind. So Dish AZ is a partnership between Arizona State University Southwest Interdisciplinary Research Center, aka CERT, and then Arizona Department of Health Services. And on the Dish AZ team, we have our amazing academic detailing program manager, Rocco Cook. We have Dr. Kevin Carmichael, Dave Watt, and myself. We all bring various skill sets and lived experience to our work. All right, so why gender expansive care? So when we look at the percentages, and this is how I explain the data when I'm in an academic detailing session, when we look at the percentages, they look really small, right? 0.73%, 1.54%. And these are the numbers of folks who identify as transgender in Arizona. So when we look at these percentages, they look really small. But what I ask folks to do is ignore those percentages, really bring back the human aspect to it. So when we're looking at the raw numbers, we're seeing for adults 18 and over, 41,200 people. When we're looking at youth, we're seeing 7,300 people. So that's a whole lot of people who are at risk of being discriminated against in the healthcare setting. We know we can watch the news, read articles, and there's a lot of discrimination that happens within gender expansive communities. All right. And the second big reason why we focus on gender expansive care is we look at HIV rates. So according to the World Health Organization, transgender people are 13 times more likely to be HIV positive. And some of the reasons include discrimination, violence, legal barriers, and of course, stigma. All right, so let's take a look at lived experience. So what is lived experience? The simplest definition is the knowledge and understanding you get when you have personally lived through something. So there are many benefits of lived experience. This includes a very intimate understanding of the topic, again, intimate knowledge of the challenges that comes with being gender expansive, awareness of related processes and procedures when it comes to transitioning, and the knowledge of related resources. All right, so I bring the lived experience part on the Dish AZ team when it comes to gender expansive care. I socially transitioned in Flagstaff, Arizona in my senior year of college. I medically transitioned in Phoenix, Arizona. So with my lived experience, I have experience navigating gender affirming medical services like hormone therapy, gender affirming surgery. And then I also have experience navigating gender affirming mental health care services, primary care services, emergency medical services, and much more. I also have experience with accessing support services and volunteering with community-based organizations. So with all of this experience, I utilize it every single day in academic detailing. Teamwork. So lived experience is great and it's very useful. However, it is not, I personally have found it is not a sustainable practice without implementing teamwork. So we utilize diverse team throughout the entire process. So creating the toolkit, we had a multiple person committee. Finalizing the toolkit, this was a multi-stage review with many eyes on the toolkit from many different fields. And then setting up the AD sessions. My colleagues set the stage. They promote gender expansive academic detailing during their AD sessions, and they are able to link gender expansive to all of our other topics, and they stress the relevance of it. And then conducting the AD sessions, the colleague support is critical in this. It can be taxing, very rewarding, but it does come with some emotional stress at times. So my colleagues are excellent with providing that support. And along with the support, they bring the cisgender experience to the table. This can make the gender expansive academic detailing much more accessible when they can see cisgender folks mirroring the advice that we're giving when we're doing the academic detailing. All right, so getting into the toolkit introduction, we start off our toolkit with setting the scene, showing the data of gender expansive folks within Arizona. And then we supplement this with also knowing and acknowledging that we don't know much about gender expansive populations as a society. So the US Census does not have any gender identity questions listed. The Arizona Behavioral Risk Factor Surveillance System only provides very limited information. And the CDC supports the fact that not much is known about gender expansive population. All right. So in addition to the data, for the introduction of our toolkit, we have the gender unicorn. This is a very good tool to explain certain terminology like gender identity versus gender expression, sex assigned at birth, and then the differences between being physically attracted to certain sets of people versus being emotionally attracted to. So this is a very good way to explain some of the basics of gender expansive communities before we really dive into the academic detailing. All right, so for our first key message that we have, it is create a safe and welcoming environment for gender expansive patients. The suggested actions that we include are updating EMR and related forms with current names and pronouns. Ensure that there are affirming materials visible. This can be things like cute rainbow stickers. It can be showing flags or having flags at the front desk, making restrooms gender neutral, ensuring all patient interactions use affirming names and pronouns. And this also includes when we're doing academic detailing, it includes reviews of dead naming and misgendering. And we also use the data that you see on the left-hand side to make the case for this key message. So we can see these percentages of people not wanting or not being able to receive care due to the social determinants of health, not being able to afford care, experiencing serious psychological distress before the visit. And then 12% of folks reported that a professional tried to stop them from being transgender. And this can happen in the medical field as well. And then we also see that 33% of respondents had a negative healthcare experience within the past year. So this just helps build the case for wanting to create a safe and welcoming environment. All right, key message 2. We encourage our clients to use a patient-centered lens to identify health risks and needs with gender expansive patients. So when we're doing this, we go over what we want to do when a mistake happens. So if an instance of dead naming or misgendering occurs, we go over what we want to do. So we want to acknowledge the mistake, apologize, and move on. I often explain no one likes a belabored apology. It's very awkward for everybody involved. Keep it short, sweet, simple, and then move on with what you're doing. What we don't want to do is focus on our own feelings, pretend like it didn't happen, say, I am really trying, put blame on the patient, dwell on it, and explain why you made your mistake. I During this portion, I like to remind folks, why we're doing this work, why we're involved in healthcare in the first place, right? We want to be there and support people, see them succeed and be happy and healthy. Um, but when we make a mistake, we can severely impact our goal of allowing them to be happy and healthy. Other suggested actions is conduct appointments and interactions in a way that empowers the patient. This includes using the informed consent model, taking a collaborative approach with the patient, and also being culturally responsive. All right. Our third key message is asking about sexual health needs at every appointment. So I like to explain when going over this key message that gender affirming hormone therapy can greatly impact somebody's libido and their sexual functioning. So we want to make sure that we're checking in with the patient regarding their comfort level of discussing sexual behavior first and their sexual health needs. I like to explain that the topic of sex can trigger gender dysphoria with some folks who are gender expansive. So we want to be very careful about the terms that we're using. We want to ask the client and the patient the terms that they use for their body. So we're not causing them to shut down before the visit really even begins. Once we have that consent, we want to ask about reproductive health needs and pregnancy needs. I like to explain that gender affirming hormone therapy does not necessarily make somebody infertile. And I often bring in my lived experience with this. I like to keep gender affirming AD very lighthearted. And I like to bring humor into it. So I explain to folks, like, this was something that was eye-opening to me when I transitioned. I had a provider that had to sit me down and explain this to me because I was baffled by it. So I found keeping it very lighthearted and really bringing in those stories goes a very long way. And then I let them know that it's important to discuss PrEP and PEP with all sexually active patients, and then offer PrEP to all patients who experience risk for HIV, regardless of their gender identity. Prescribe PrEP to any patient who requests it. And then our fourth key message, we want to offer services that address the intersectional complexity of whole person gender affirming care. So the suggested actions are avoiding focusing solely on the patient's gender expansive identity. We can't assume gender related care is the only health concern. Right? When somebody is gender expansive, that is not all of who they are. We still need flu vaccines, RSV, blood pressure screening, things like that. And then we want to ask patients what their needs and concerns and priorities are at the start of the appointment. And then you can explain what your needs and priorities are. And we want to ensure that referrals are made to specialists who will validate gender expansive patients' identities. Oftentimes we are working with rural communities and this isn't always possible. So when it's not possible to refer to somebody who is going to be affirming of the gender expansive patient, really being transparent with the patient can go a long ways. It lets the patient know that this is something that's on our radar. We want to make sure you are affirmed. Unfortunately, we can't send you to somebody who is affirming. We just don't have those resources currently available. And just letting them make the choice for themselves. And then we also want to offer family planning resources to gender expansive patients. All right, so getting in the door, we have done this in a variety of ways. We have gotten in the door by organizing and conducting a gender affirming care community of practice. We hold sessions monthly. We've gotten several academic detailing sessions out of this. And then we talk about gender expansive AD when conducting that first introduction AD session and doing that needs assessment. And then we emphasize the link between HIV and people who are gender expansive when we're conducting HIV-related AD sessions. All right, so just a couple of observations. Gender expansive AD has been very well received by clinics, community-based organizations, and city health departments. And our team has been contacted by multiple organizations actually requesting gender expansive AD, as well as medium to large group presentations. All right, so some of the common questions we get are pertaining to names on forms. So oftentimes when we're doing academic detailing sessions, we get asked, like, how do we handle a situation of, you know, making sure we're using the correct name on a form, but also explaining to the patient that if they have not changed their name legally, that insurance will still use their dead name. Oftentimes I will let them know that it is still beneficial for them to have the patient's name that they go by on their form. And again, be transparent with the patient that you will still see your dead name on documents as it pertains to insurance and even with pharmacies. And then the next most common questions pertain to showing support to gender expansive patients and clients without offending anybody else. So I have a note down here. If and when this occurs, I like to suggest that they politely tell the patient who has raised the concern of having affirming materials visibly present that our goal is to provide the best healthcare aim for and for the best outcomes for all patients, and having affirming materials assists greatly with that. So I have found that that can be a hard thing to argue when somebody is telling a patient, like, we are trying to provide the best care for everybody. And this is one way that we're able to do that. All right, so thank you all so much. Please feel free to email or call me if you have any questions. If you're not comfortable with sharing those questions today in the chat.
Thanks, Ryan. Thanks for an amazing presentation and also for sharing your personal experience as well. We so appreciate it. And diving into all of those key messages was so helpful, I know, for me. So I'm sure it was helpful for the rest of the community as well. I see a question in the chat for you, Ryan, from Bevan, and I see some cheering from your team. You shared that this campaign was well received. Did you hit any roadblocks or pushback from any clinicians at all? And what kind of pushback did you receive and how did you respond?
So that's a very interesting question. And when I first started this work, I was prepared for that. I mentally prepared myself. My team and I had many conversations about that. Surprisingly, no, we have not received pushback from clinicians. they've had questions of how to approach certain things, but really no pushback.
That's amazing and wonderful and inspiring and hopeful. It's makes me feel hopeful. That's really something that we could all use a lot of. So thank you. Back to you, Anna.
Thanks, Ryan. Jackie says, not a question, but I love your take on the key message. One, data, focus on the people. In my former state of Nebraska, these folks would be the third largest town in the state. That puts it into perspective, Jackie. Some more comments, Ryan, coming for you that are very positive about your presentation. And then Amy asks, hi, Ryan, I work with a practice that recently asked me for affirming materials, especially for teenagers, patient-facing materials. Do you recommend anything in particular?
I actually have a list that I can send out if that would work.
That works great. And we can add it to our resource list and put it also on our Summit Hub. That would be awesome, Ryan.
Yeah,
right.
thank you. That would be lovely. All right.
Any other questions for Ryan? A lot of thank yous in the chat, Ryan.
And if questions come up later, as always, please, please continue to pop them in the chat box. We'll get to them when we can. So, or if you want to be connected with Ryan, as he mentioned, we're happy to do that as well.
Awesome. Thank you, Ryan. And thank you to the Arizona team for doing this work. This is amazing. All right. Excellent job, Ryan. We will see you soon and chat soon. We are going to move into our next presentation of this session. So we are going to be hearing from the team in New York City, and Wendy and Nina will be presenting. So I will hand over the mic to Wendy and Nina. Welcome, guys.
Great, thanks so much. We're really excited to be here today to share our experience talking about our latent tuberculosis infection campaign. My name is Nina Shabbat, and I am the evaluator for the public health detailing program at the New York City Department of Health and Mental Hygiene. And I'm here today with my colleague, Wendy Agrone, who is one of our outreach representatives, to talk about our experience.
All right, thank you, Nina and Wendy. We are going to start with a chat waterfall. Nina, would you like to read the question to everyone?
Sure. What types of stigma are associated with tuberculosis?
And you can type those answers in the chat. Bevan says poverty, immigration, contagious, incarceration, dirty, fear of transmission. What do you think about these coming in, Nina?
Yeah, absolutely. These are all among some of the themes of stigma that came up in some of our formative research and our focus group discussions with, with the target population for this campaign. So absolutely.
And I want to bring up two more that are just coming in too, that it's an old disease that we don't need to worry about anymore. It's ancient and crowding.
Mm-hmm.
All right. Take it away.
All right. Thanks so much. All right. So our plan for our session here is just to talk through what is latent tuberculosis infection and why did the health department decide to embark on an LTBI campaign. Then we'll talk about how we applied a health equity lens to our campaign. And then I'll turn it over to Wendy, who will actually walk through some of our materials and some of the provider and patient education feedback, and then walk through some spotlights on some of the provider comments as well as community feedback. And then lastly, we'll take some audience questions. Okay, so just to start off, I know people are likely familiar with active tuberculosis, but you may be less familiar with latent tuberculosis infection. And you may hear us refer to this as latent TB or latent tuberculosis infection or LTBI. They are all interchangeable terms. But essentially, latent tuberculosis occurs when a person has been infected with TB bacteria, but the infection remains latent in the body. People with LTBI do not feel sick and cannot transmit the bacteria to others, but they are at risk of progressing to active TB disease, where they can become sick and are contagious to others. LTBI is actually extremely common. Millions of people worldwide have LTBI. So interesting to hear the sort of stigma around it being an older disease, as it's still something that's extremely prevalent in a global perspective. But the good news is that taking medication can prevent progression to active TB disease. Next slide, please. So why did we decide to conduct an LTBI campaign? First off, the COVID-19 pandemic reversed years of progress in reducing the burden of active TB worldwide, for all the reasons that, healthcare overall was disrupted with just lack of access to resources and changes in, availability and people being able to access their regular care. So that was certainly something that impacted the ability to fight TB as well. But it remains a significant public health challenge, also because of global inequities in resources for diagnosis and treatment. Here in New York City, the rate of TB is more than twice as high as the US national rate. And every New York City neighborhood saw at least one case of active TB, but significant geographic differences exist in where the cases are primarily occurring. And there are certain groups of New Yorkers, which we'll discuss, that are more impacted than others. One study found that the majority of people diagnosed with active TB disease in New York had preventable or potentially preventable cases. And the progression to active TB disease was frequently the result of missed screening opportunities or failure to initiate treatment for LTBI. So we felt that this was a problem that was really ripe for intervention at the primary care provider level, because they are the people that are more likely to encounter somebody that might have one of these potentially preventable cases. So just to give you a little bit of background on our campaign, as with every detailing campaign, we had a series of key recommendations that our outreach representatives shared with the providers at the top of every visit. For this campaign, the key recommendations were, first off, to screen for risk of LTBI in all patients annually using the New York City TB risk assessment tool. To test patients that meet any of the criteria on the New York City risk assessment tool using what's known as an IGRA, which is a blood test. Recommendation number 3 was to rule out active TB disease with clinical evaluation, chest X-ray, and other diagnostics as clinically indicated. Number 4 was to treat LTBI using a short course regimen and counsel patients on the importance of treatment adherence. Some people may be aware that previously some of the medications used for TB were, could take several months, like 9 months to complete the course. And so part of our campaign here was to introduce medications that were a bit of a shorter course could be as short as 4 months. So that was a significant change in practice that we wanted to encourage. And then lastly, the final key recommendation was to report any patients with suspected or confirmed active TB disease and children under age 5 with LTBI within 24 hours to the New York City Health Department. Just to give you a brief overview of what the rollout of our campaign looked like, it was conducted last year between May and September, and it was staffed by 3 outreach representatives and 1 outreach coordinator. We detailed 373 providers and 315 staff members at 208 sites in selected neighborhoods of Brooklyn, Queens, Manhattan, and the Bronx. We targeted all adult primary care providers in the selected neighborhoods. And we define adult primary care as internal medicine and family practice providers. Overall, the campaign was well received and practices were welcoming of our detailing representatives. And Wendy will speak a little bit more specifically about the experience in the field. And And then lastly, in recognition of this campaign, the PHE team and our colleagues in the Bureau of Tuberculosis Control were honored as 2024 CDC U.S. tuberculosis elimination champions for contributions to eliminating and preventing TB in the U.S. So moving on to talk about how we actually applied an equity lens to LTBI for this campaign. Here at the New York City Health Department, addressing health inequities is an integral part of all of our work. So it's something that we try to take into account and integrate in all of our campaigns, not just the LTBI campaign. But we did feel like taking active steps in this campaign to address health equity was critical to the campaign's success. Again, extremely important to note that certain groups of New Yorkers are disproportionately impacted by LTBI, including people born outside the US, non-Hispanic Black individuals, and Black individuals. We applied health equity or considered health equity through 3 different components in this campaign, through the development of the campaign, meaning like the action kit development, the materials development, the key recommendations, through the execution, meaning where we actually launched our campaign and how we went about operationalizing it, and finally the evaluation, so measuring the campaign's impact and communicating its findings. In development, we considered health equity through active collaboration with our target patient populations to develop culturally responsive materials. We always conduct some formative research and focus grouping to get feedback on our materials. But in this campaign, we conducted the focus groups in 4 languages: English, Spanish, Mandarin, and Cantonese, to determine if the materials resonated with our target audience. We also worked with health literacy experts to ensure that the materials were accessible in terms of fundamental scientific, civic, and cultural literacy. What that means is, in terms of the civic and cultural literacy, moving beyond just kind of making sure that we were using like accessible language, but also thinking about themes of like understanding how health insurance works in New York City, and the role that a government agency like the New York City Health Department might play in a communicable disease like TB. So just also making sure that those messages were accessible and understandable to all of our target populations. In the focus groups that we held, there was significant discussion of stigma. And so we made sure to incorporate that messaging through all of our materials, and made sure that that was something that really was also communicated in both patient and provider materials to help encourage patients to adhere to the medication if they were found to have LTBI. So moving on to how we applied an equity lens through execution of the campaign, the primary mechanism was through neighborhood selection. We reviewed internal New York City Health Department data to determine the zip codes that had the highest TB burden, which we defined as active TB cases among residents. So those neighborhoods were at the top of our list for inclusion, and you can see on the right a map of New York City with the neighborhoods that were selected for inclusion in red, and those that are darker are those where there were more practices that fit our inclusion criteria, and so there were more detailing encounters in those practices. But you can see it covers a wide swath of the city. So those areas with the highest active TB cases among residents were included. And then in instances where a community had roughly equivalent case counts, areas identified as task force for racial inclusion and equity neighborhoods were prioritized for inclusion. A task force for racial inclusion and equity neighborhood refers to a designation that was created by New York City agencies during the COVID-19 pandemic to identify neighborhoods that were disproportionately impacted by COVID and that experienced additional inequities in health and other socioeconomic factors. So those neighborhoods were then included in our site list as priority neighborhoods. And then finally, in evaluation, we applied an equity lens by interpreting findings and collecting data using an equity framework. In this context, we reviewed how the results might be interpreted and worked to avoid language or framing that could contribute to reinforcing structural racism or stigmatizing particular communities or groups. We also considered how our analytic choices might highlight or mask information. So for instance, when we reported out our findings, we considered if we should report all of our findings, aggregating all of the results into one larger report, or if we should do some sub-analyses perhaps that looked at different groups, like let's say by neighborhood or specialty or something to that effect. And so those were all the kinds of things that we considered when looking to integrate health equity into our work. So now I'm going to turn it over to Wendy to talk about some of her field experience with this campaign.
Great. Thanks, Nina. Good afternoon, everyone. So I'll be going over some of the campaign in action and supporting practices, some of the experiences we had out in the field with interactions with our providers and staff in the community. So partnering with providers is extremely important with public health detailing. It's a really two-way street, so bi-directional partnerships with our providers, and we do this by promoting provider education on critical public health issues and how they can mitigate.
Uh-oh, I think we lost Wendy. Wendy, can you hear us?
Yes.
Okay, we can hear you now.
Here
We lost your video though.
Can you see me now?
Yes.
Awesome. Okay,
Thank
we're back.
you. All right, we're back in action.
Rewind. Okay, so developing partnerships with our providers is bi-directional, as I was mentioning. We do this by promoting provider education on critical public health issues, on how they can mitigate associated health disparities through patient education. We also soliciting and implementing feedback from providers to improve detailing best practices and campaign materials. So as I said, it's a two-way street. We not only go to providers to give them information and resources, in this case being LTBI, among other topics that we've had campaigns on, but we also want to feedback back from our providers with regards to what kind of information they would like, what type of resources they need within their practice. And providers have different needs within their practice, because oftentimes we do visit larger sites that are affiliated with a hospital, and so they have tons of resources. And then we go to much smaller sites where it's kind of a one doc in office, a couple of staff members. And so we meet them where they are and we try to provide them the best resources so that they can support their patients. As part of these partnerships, we also help providers overcome reported barriers to implementing the key recommendations that Nina mentioned earlier. So with all of our campaigns, we have key recommendations. For this particular campaign under LTBI, there were 5 key recommendations, and ideally the materials that are in our action kit are to address each one of those key recommendations. So as I said, we meet providers where they are within their practice. And we try to get them to implement, and we try to address and overcome reported barriers by employing persuasive communication, enabled by active listening. So we really actively listen to our providers, hear them out, and meet them, as I said, where they are. We provide data to demonstrate the local impact and need for action. And we also, of course, highlight relevant kit materials that speak to the identified barrier. I'll go into barriers in the next couple of slides. Promoting provider education, again, very important within the public health detailing campaigns. Provider education serves the purpose of, 1, informing providers on public health topics using peer-reviewed articles, clinical guidelines, and vital statistics on evidence-based care. Secondly, providing healthcare providers and other clinical staff with communication strategies for enhanced clinical interactions. So we really want to take this opportunity that we have with our providers and give them the resources, the tools, the clinical tools, so that they can support their patients as best they can. Provider education materials in the LTBI campaign included screening, diagnosing, treatment, and billing guidance, support for first-line prescribing practices, instructions on how to report LTBI and active TB disease, and guidance on how to destigmatize LTBI through strategic communication practices. Awesome. So promoting patient education is a really big component of public health detailing. Patient education serves the purpose of, one, prompting discussions with providers and other relevant staff. So oftentimes when we go into the sites, the first encounter is not with the provider. So the first encounter is often with a staff member, a nurse, front desk staff. So we also not only give these resources to the provider, of course, our target is the provider, but we also have discussions with staff, nurses, anyone within the site that has that one-on-one interaction with the patient, because it is very important. Sometimes the patients feel even more comfortable talking with a nurse, or they have more time to talk with the nurse. And so we make sure that everyone within the office has this information and know what's in each one of these patient education materials, so they can, if a patient does ask them a question, they know exactly what to give them, something that's tangible, something they can go home with and look at it once, when they have the opportunity. We also, patient education materials also encourage two-way discussion so that there are no missed opportunities for care. Of course, as I mentioned, the staff person, provider, anyone within the practice can definitely have those interactions with patients. Addressing all literacy levels and multiple languages. So as Nina mentioned this earlier, all of our materials, especially for this particular campaign, for the LTBI campaign, providers really like the fact that we had all of the materials available in the languages that their patients spoke. So all of our materials are translated into the top 13 languages spoken in New York City. So that was really a great incentive that providers really liked, that we had the materials available to them so that they can support their patients who had, who's not only couldn't understand the English materials, but had a different preference with regards to patient education. Patient education materials in the LTBI campaign included information on how to get tested, if at risk for TB infection, and what treatment options are available, common answers to questions about first-line treatment options, such as rifampin and INH, as well as rifapentine, resources on where to get free LTBI evaluation and treatment, such as the New York City Health Department CHEST centers. So oftentimes we did offer resources to providers, referral resources, but there were some sites that already had resources in place or referral services in place. And so, as I mentioned before, every site was different. Some sites were smaller, needed additional resources and referral information, and some sites were much bigger where they already had these systems in place. In this slide, these are some of our most popular materials for the LTBI campaign. Again, all of our resources are available at nyc.gov/health. Just look up LTBI and all of these resources are available to you. Under provider resources, we have latent tuberculosis infection screening, diagnosis and treatment guide. This was really helpful for providers who really wanted to have a streamline within their practice with regards to screening, diagnosing, and treating their patients. We also have the guide to prescribing treatment for latent tuberculosis infection. This was really popular among our providers. What we realized at initial visits when we went into the clinics and the sites was that providers were using kind of like the old school treatment method, which was a very lengthy treatment, which is called INH. And it was about 6 to 9 months of treatment. And so this gave them the opportunity to really look at other options for treatment. And some of our providers were able to implement those treatments within their practice. We also have the Do You Need a TB Test? That was a questionnaire which allowed providers to easily implement into their practice a quick screening tool for them to have patients fill it out during their wait time, and then hand it in to either the nurse or whoever had that first encounter with the patient. To your right, we have the clinical tools and patient education materials. These were some of our most popular as well. One of the biggest barriers reported to us by providers was medication adherence. So because the treatments are lengthy, providers were, requesting ways in which they can help their patients kind of stay on track. And so we have the My Tuberculosis Infection Medication Tracker, which is also available in an electronic form as well that we provided to our providers. And they were able to, in turn, give this to their patients, and they're able to track like their daily intake of medication, as well as what was also popular was the common questions about INH and rifapentine, the combo treatment, and the common questions about rifampin. These were really popular because oftentimes what stopped patients from continuing their treatment was very common side effects. And so this had a really nice layout of what to expect when taking your treatment, with the kind of common side effects that can occur. And so if they experienced this, they knew that this was very common and they can continue their treatment. Whereas beforehand, they were kind of discontinuing the treatment and sometimes would return back to the provider and sometimes they would not. And so these tools are really popular among the LTBI campaign. So provider spotlight and community feedback. You can go on to the next slide. So these are just some notes from the field that myself and my colleagues shared during our team meetings. And so when you look at the smaller boxes, I'm going to start with the one on the left. So we often offer grand rounds at larger sites. So this is just a provider saying that the grand rounds presentation was informative and comprehensive and answered all of the questions regarding LTBI. The other smaller box to your right, this one actually had a practice change within their site. So this site called their manager and had the IGRA test incorporated into the EHR because they wanted to be able to test patients annually. So they put this into their EHR system, like electronic health record system, and they were able to in turn test their patients annually. As I mentioned before, we often see changes in practice during our follow-up visit, which is usually 4 to 6 weeks after our initial visit. And so these are some of the provider comments that we got at our follow-up visit. The first one to your left says, at follow-up, provider shared that he started a patient on combination therapy instead of using the longer course regimen. Going forward, he is also going to treat patients himself rather than referring out to a specialist. So this was great. As I mentioned before, at initial visit, providers were using the old school method of treatment, or they were not treating at all and they were kind of referring out to either a chest clinic or referring out to another specialist within the practice. And so this also, there were a lot of practice changes where providers were in turn using a shorter course regimen and also treating their patients, which was great. And lastly, at the last box to your right is at follow-up visit, a provider stated, since my visit, he reviewed the prescription guide and they are testing more. And he has started multiple patients on rifampin, the majority of which had always tested positive but had never been treated. When given the option of INH for 6 to 9 months or rifampin, which is 4-month treatment, patients chose rifampin. So as you can see, that's one of the main barriers to care and treatment was that the INH was really long treatment, 6 to 9 months. And so provider was then able to offer rifampin as a treatment method, which reduced their treatment time to 4 months. And this is just some provider and community feedback that we received from some of our sites and providers. Many providers reported that they very much appreciated having a direct contact with a health department representative, and the PhD team connected several providers with clinical experts in our TB bureau for assistance with specific cases. So this happened often. So we have that one-on-one interaction with with our providers and other staff members. With this particular campaign, with the LTBI campaign, these were sites that had never received visits, or maybe had received visits long time before. And so they weren't too familiar with the public health detailing program. And so they were really welcoming, really open to getting the resources and materials from the public health detailing team. And as well as they also had special case circumstances where they reached out to us. Hey, you came to see me 4 weeks ago. I have a case where I need some assistance. And we were able to connect them to our TB experts for further assistance, which was great. Resources like the provider communication guide were helpful at addressing stigma and to communicate the seriousness of LTBI despite the lack of symptoms. So providers will constantly tell us patients are positive for LTBI, but because they're asymptomatic, they don't have any symptoms, they're not coming back for treatment, they're not following the treatment regimen. And so we were able to offer them provider communication guide to help them address that with their patients. And having materials, as I mentioned before, in the appropriate languages was key. We received requests for materials in Russian, Nepalese, Hindi, Albanian, Ukrainian, Burmese, and Uzbek. So those were some of the requests that were made. We tried our best to fulfill all the requests made. And as I mentioned before, all of our materials were available in the top 13 languages spoken in New York City. And thank you so much for your time on behalf of myself, Nina, and the rest of my team, the PhD team. All of our materials are available online by visiting, as I mentioned before, nyc.gov/health and searching LTBI. Happy to answer any questions.
Thank you so much.
Thank you, Wendy and Nina and the New York team. We so appreciate you. If you have any questions, please do add them into the chat. I already see a question from Mary that I'd love to ask you. She said, do you all use surveys for provider feedback? And Nina, maybe you can speak to what content you put on the surveys if you do use them.
Sure, yeah, happy to take this one. We do collect information from every provider as part of our assessment process. Actually, our representatives, before they deliver the key recommendations, ask a series of questions to determine what the provider's current clinical practices are. And then they ask the same questions when they go for their follow-up detailing visit. And that is what forms the basis of our evaluation of the campaign to look at the change in practice. In terms of kind of like larger surveys looking at just general feedback on the public health detailing program, we've done them. We don't do one for every campaign that we do, but we have done some like just kind of general customer feedback surveys, for lack of a better term, to kind of understand what people view as like the strengths of the program and the weaknesses, and you know what else they would like to see if there's particular topics. Our reps also collect a ton of qualitative data while they're out in the field. In addition to, for example, some of the notes that Wendy shared, we have a weekly staff meeting where we discuss some of the feedback that we're hearing in the community, and you know, a lot of kind of program feedback is shared through that. And we also kind of spend a lot of time talking about resource needs that the providers are asking for, whether that be for, you know, things that relate to the public health detailing program, like campaigns on specific topics, or if that's something like, hey, I have a patient that needs X social service, like how can you help us with that? Because you know, as being part of New York City government, we get a lot of requests that are not just related to the delivery of public health services. So yes, I hope that answers the question.
I'm sure you see it all. And, you know, in terms of it just being an ongoing loop where folks come to you and ask for what they need, you know, that's something that I know a lot of our folks in smaller health departments and smaller organizations really would love to have happen, would love to have folks reaching out, and in particular would really love to have folks actually respond to their surveys. Would you be willing to share a little bit about how you get folks to respond? We've had a little bit of stuff going on in the chat, where some folks say they get a better response rate when there's a piece of paper in front of them that they have to fill out on the spot, and others do better with e-surveys and all of that good stuff. So can you speak a little to just best practices on getting provider feedback?
Sure, absolutely. And Wendy, feel free to join in with your experience if I miss anything. But I mean, I will share. We also have a challenge. We have low response rates for surveys that are kind of more the larger program feedback surveys. I think that is just a challenge of doing that type of survey research or outreach. It's just very common. In terms of the response to our assessment questions, that's really part of our detailing process. So our representatives are standing in front of the providers, asking them head on to please answer these questions. So it's very difficult to turn them down. And I think, Wendy, you can probably speak to this better than me, but when we say we just have 2 minutes, we just need you for 2 minutes, and then that can become a 10 or 15-minute conversation where there's a lot of back and forth. I think this really speaks to our sort of bi-directional approach, where we're trying to not just be sharing information and putting out the messages that we as a health department want to promote, but also be, ensuring that we're hearing from the providers as well and what's a priority for them, because that helps to build the trust and build the relationship over a longer period of time.
Yeah, for sure. Just to add to what Nina mentioned, I think that I know someone mentioned that the paper is often, better received. And then there is some truth to that. When we do group presentations where the assessment questions we do have a QR code that we provide providers with, and we have to kind of be on there to make sure the questions are answered, because oftentimes, unfortunately, they're not. And so, but when we offer a paper form, it's collected. I'm able to collect it, and so we have more of a success with regards to having those assessment questions answered with the kind of hard copy. But it's dependent on the site. Yeah, it's dependent on the site. But we do try our best. But there is hit or miss. Sometimes you get providers to complete the questionnaire or the assessment questions, and you don't get 100%. Sure.
Yeah. But it sounds like getting that qualitative feedback has been a bit easier. And so I think a lot of times when people don't feel put on the spot, but they're just having a conversation, that's just such a nice way to kind of grab what they're sharing with you. Wondering sort of how, if you all have a system for that as well, in terms of if someone's sharing an awful lot, as a detailer, Wendy, do you just try to grab it all and then run to your car or the subway and just jot it all down? Like, what do you do there?
So it's very conversational with those providers that I have been able to build relationships with, and the other providers where, it does require a little bit more of several conversations. Sometimes they give me 5 minutes. Next time I come, they give me 15. And so it is, it definitely leads up to it, but then it depends on the provider. Sometimes I get there and providers will tell me they have 5 minutes, and when I'm done, I was there for 40 minutes. And so it's dependent on how much time the provider is able to sit and chat with you. It's dependent on how much information the provider would like on a particular topic,
and how much they value you and your service as well, right? Some folks may say, I only have X number. I mean, how do we all feel when we get a call or someone knocks on the door for something? You say, I only have a couple minutes. And then if you're into it, you're like, I guess I have a little more time. So yeah, lots of psychology here about how to hey man, it's behavior change through and through. You're trying to get people to do something that they might not want to do, right down to the survey. So we really appreciate that, and some great feedback in the chat. We have from your colleague, Michelle Dresser, that even incentivizing providers for general online e-surveys yields low response rates. Yep. And so I think it sounds like, to some extent, and Nina and Wendy, correct us if we're wrong, expecting not the highest yield from that is just something you got to go in with to feel like, you're keeping yourself sane and not feeling a huge disappointment when folks don't respond. Does that sound accurate?
Yeah, absolutely. And I think that's consistent across not just public health or detailing, but across a lot, all different disciplines.
Sure, sure, sure. We have another question from Mary Nagy. Did you cold call in person to get in? She also shares that coming back to AD after taking a break during COVID, she's recognizing how things have changed around gaining access. Could you speak to what you did for this campaign? And then could you speak to whether you've seen trends change in terms of what the best approach is? Does it really depend on the topic, the clinic? Anything you can share there would be great. Wendy, what do you think?
Sure. So it's I hate to keep saying this, but it's dependent on the site. There has been a lot of changes after COVID. There were sites where prior to COVID, I had great relationships with. I would come in, hey Wendy, what do you have for us today? And then when we came back post COVID, new staff members, different policies in place, and so it's kind of starting over. And then there are sites we don't make phone calls initially to see our providers at a site. We just kind of stop by, and if we're lucky enough to see the providers and staff, great. Most of the time it is successful. To when we get there, what we find is that when we make phone calls and we try to make appointments, oftentimes they're like, well, no, this is not a good day, this is not a good week, next month, 6 weeks. So we find that the best approach is just to kind of appear and offer the information, tell them why we're there, offer the resources. Incentives are, as Michelle mentioned, we come with some swag. We come with some PhD swag. We give pens. We provide them with the kits. We tell them of all the great resources that are within the kit. A lot of times, the gatekeepers, who are the front desk folks, sometimes are the barrier for us. And so kind of getting past that can be difficult, and sometimes it's not. Sometimes we get there and the front desk person will say, oh, just go right on through. And I love sites, but it's not often like that. So it is developing relationships, making yourself, a resource for them in the community. And as I mentioned, we do have a set number of sites that we have already established relationships with, which are much easier to come back to. But for example, for the LTBI campaign, as I mentioned, these were sites that were not our usual sites. And so it did require us to come in, introduce ourselves, public health detailing, what we're all about, before we were able to then go into LTBI. So it's been a great experience. Everyone's been really welcoming, and we haven't had, of course, we have a couple sites that sometimes are not interested in getting the resources, very few. But we find ways to sway them to obtain this.
Yeah, I mean, it sounds like it takes all different types of approaches all at once, just diversifying those approaches. Anna wanted to ask about whether or not the things that came up in that chat waterfall about sort of big picture stigma for folks who have TB. Did you notice any stigmatizing feedback come up from clinicians themselves, however subtle, about these populations who are dealing with latent TB? Did any of that arise?
Oh, absolutely. Absolutely. We did come across providers who would use statements like, these people, or, kind of, I honestly think it unintentional, seems like, in conversation, or sometimes they don't realize what they're saying. And so, yes, it absolutely came across in our conversations with some providers. And that's when you take the opportunity to offer communication strategies and ways to talk with their patients about this particular topic. And so, yeah, we try our best to tell them how it is. Like, this is what we're seeing, and we try to destigmatize LTBI by offering resources and information. And we kind of highlight that section for them, not, directly telling them that this is the kind of how we're feeling, but having them be aware of it. And so don't continue to, unintentionally offend a patient or anyone that they encounter in their practice.
Yeah, and that's so important, especially with our theme, this year of looking at our own sort of implicit biases. As you said, many times, most times it's unintentional, which can make it harder to kind of smoke out. Ryan, not sure if you're still there, but if you are, and you can pop your camera back on, just wanted to close up this session with a question for both groups around stigma. So when it comes to language use and, beyond the latent tuberculosis campaign, because Wendy, I know you've been doing this for a long time, as have you, Nina, and I know Michelle's on the call as well. Where are you seeing the need most for an understanding and an increase in knowledge around patient-centered language for clinicians with whom you're meeting? I'll throw that to you, Ryan, just first to kind of let us know, where are you seeing the knowledge gaps about how to provide culturally responsive care with the work you're doing? And then I'll turn it to New York to talk either about this specific campaign or any of the campaigns you've worked on where you've seen a gap around providing, culturally responsive language education to providers. Ryan, what do you think? Where would you say you saw the most need for education? And you are muted.
Thank you. When it comes to talking about specific body parts and also pronouns, that's we spend a lot of time talking about language, especially when we're working with clinicians who are very scientifically oriented. So when we're talking about, genitalia, for example, certain terms are often used in a clinical setting. So explaining gender dysphoria, I'm really spending a lot of time on how do we prevent patients from shutting down just based off of the language we're using. So that's where we spend a lot of our focus. Does that answer the question?
It does. And so really it's how do we prevent, it sounds to me like what you're saying is how do you prevent patients from shutting down by being unaffirmed? When they're not affirmed, how does that recreate a sense of trauma for them, or at minimum, just not being honored for their identity? Wendy, Nina, Michelle, any way in which you'd like to address that question, just where broadly you've seen trends where providers need education around language?
Sure, I can speak to that a bit. I think one theme that we really have been working to convey through all of our campaigns and through the work of the health department is the role of structural racism in shaping health outcomes. We hear, there are elements of like personal responsibility, of course, that shape health outcomes, but that's something that providers may overemphasize and they may be less aware of the role of structural racism in shaping those outcomes. So that's something that we've been really trying to work with providers around and incorporate into all of our materials, even if the campaign may not be quite as is directly focused on those topics. It's something that a message that we've been really trying to put forth in everything we do.
Well, that's so important. Yeah. And I know that, us speaking with Carla and just knowing you all for quite some time, and just knowing that you guys have always been pioneers in looking through that lens and really trying to get down to the structural level on that. So thank you, Nina. Final question from our colleague, Vishal Kinkabwala in Michigan. He asks, and this is for you, Ryan, what would be a great first step for starting a gender affirming care program? Again, that's a tough one to probably condense into one step. So maybe a step or two, what would you like to share? And then we'll get everybody on to their break.
Connect with the gender expansive community locally. That would be step number one, really seeing what the needs are. In that
so going out into the public and having these conversations.
Yep.
Love that. So, doing your outreach there, trying to connect with it really all goes back to a trend that Anna and I were talking about and our team that we've noticed across all of the conversations from the past 2 days, which is We cannot intuit what patients need. We must ask them. And that's such a tricky thing. As detailers, we've often learned like, no, we're over here with the clinician. We don't talk to the patient, right? That's not our job. We can make patient facing materials and, maybe we can do some surveys, but I think it's really important for us to get out of our comfort zone, of course, within our budget and really make pitches to funders and to our leadership about how important it is to make sure that all the hard work you all are doing as detailing programs is right on the nose, is really hitting the mark with what patients need. So just seeing this trend, uptick in this trend of what are the patients saying? What are the patients saying? It's really exciting for us to see at NaRCAD. So thanks for answering that. Thank you, all three of you, for speaking this afternoon. We're very grateful. Anna, back to you to transition us out and into another break before we see you for our final session this afternoon. Thank you again, Ryan, Nina, and Wendy.
Thank you again to our lovely presenters and to the attendees for great participation in the chat. We are going to head into a 32-minute break. We will see you back here at 3:45 p.m. Eastern, and we will wrap up our session with a roundtable. So really looking forward to that. And stay in this room, turn your videos off, turn your audio off, and then we will reconvene in 31 minutes. See you soon. Thanks, everyone. Bye-bye. All right. Thanks, Anshul. We are going to move into our last session, which is our community roundtable. Bevan is going to share the slides for us. And we are excited to wrap up the summit with this roundtable and get you talking with all of your peers. And then we're going to have a large group discussion. We're going to create a live resource together. And we're going to take some time to, one, look inward, look at our own implicit biases and start thinking about how we can consider that as we create our detailing campaigns. And we are going to focus on how to create inclusive detailing campaigns moving forward. So with that being said, I will hand it over to Bevan. We're going to introduce ourselves, but you already know us.
You already know us, but we'll say a quick hi and thanks for spending the past 2 days with us. You've heard me and Anna quite a bit, but we'll turn it over to Anshul. Anshul, say hey and tell us what's going on for you.
Thanks, Bevan. Hi, everyone. I'm Anshul Gupta, Program Coordinator. Really looking forward to ending our summit with this roundtable session and excited to build another tool with you all. But first, I will walk through the goals for this roundtable. So first, we'll start by level setting on implicit bias, as well as a tool that we can use to mitigate it. We'll also think about how we can use an inclusive lens throughout our detailing projects, and you'll get a chance to work through a case study in breakouts. There'll be opportunities to connect in small groups, share your ideas, and come in the large group to discuss. Again, we look forward to diving deeper into this topic, but I'll pass it back to Bevan to get started.
All right. Thanks, Anshul. So those of you who've been at a roundtable with us before or a community check-in or any sort of workshop know how we like to rock and roll. Those of you who are new are hopefully in for a treat. And what we are going to do, as has been mentioned, is just try to work together and think big picture, think outside of the unfortunate restrictions of things like reality and budgeting, where oftentimes folks will say, gee, I'd love to create an inclusive project on X, but it's just not going to happen because of Y. And Y could be, oh, leadership won't approve it. Or it could be, I don't know the first place to start. Or it could be, I'm nervous that this is going to get pushback. Whatever the why is, we are going to just try to think big today. But first, just getting refreshed on implicit bias. So of course, this is unconscious negative attitudes or prejudices, pardon me, against a specific social group. In our last session, Wendy Agron from New York City Department of Mental Health and Hygiene, talked health and mental hygiene, thank you, spoke about how folks that she met, clinicians that she met with, certainly didn't seem to have biases that were conscious, that were meant to be harmful. And I think the whole point of this is those of us who, and we all have them, aren't aware of our biases can really cause damage that we certainly don't mean to cause. So the first thing we need to do is become aware as much as we can. Otherwise, we will be compromising good health care, especially when prejudices impact patients, which they always do. And unspoken biases can be changed once we recognize them. So the first step is taking off our blinders. This is kind of tricky because if we don't know that they're there, how can we take them off? So we're going to talk a little bit about a snazzy tool that Anna has found and is excited to share with you. We always love a good acronym or mnemonic. So over to you.
Yes, and I'm so excited to share this tool with you all. So this is from the American Academy of Family Physicians, and it helps us mitigate implicit bias. So on the left, it's going to spell out implicit going down the screen. So first we have I for introspection. So explore your own prejudices. You can do this by taking implicit association tests or self-analysis tests. We have some available on our inclusivity toolkit on our website that you can take a peek at and take when you feel ready. And then we have M for mindfulness. So practice mindfulness. You're more likely to give into your biases when you're under pressure and when you're stressed. So it's important to find ways to reduce stress and be mindful through things like yoga or journaling or exercising or whatever serves you. And we have,
Anna, I just wanted to throw in too, if something like meditation or yoga makes people cringe, just doesn't feel right for them, which it does for certain people, it doesn't for others. Sometimes just observing your thoughts. So if you hear them in your head, saying them out loud to yourself is one way to take yourself out of thinking them and into observing them. A certain, way to be mindful without feeling like you need to get a 10, session yoga punch card. So back to you, Anna.
Yes, and to go off that, Bevan, there, someone once shared with me that when a thought comes in, you say, oh, hello there, and then you let it go. And that's like the first step of being mindful. P is for perspective taking. So consider experiences from the point of view of the person being stereotyped. You can read or watch content or directly interact with folks from a specific group. And L is for learn to slow down. So before interacting with people from certain groups, pause and reflect. Consider positive examples of people from the stereotyped group, such as personal friends or public figures. I is for individuation. Evaluate people based on their personal characteristics rather than those affiliated with their group. So you can do this by connecting over shared interests. That is always very helpful. C is for check your messaging. This is a theme that's come up quite a bit over the summit, but use statements to welcome and embrace differences rather than things like we don't see color, and use phrases that will embrace everyone's differences. I is for institutionalized fairness. Support a culture of diversity and inclusion in your own workplace. And lastly, we have T for take two. Be patient. This is lifelong work. You have to constantly look for new ways to improve, and you will improve over time. But this is hard work. So be patient with yourself and with others as you're doing this.
And I'd love to throw a couple little cherries on top of the last two. So with institutionalizing fairness, this may not be particularly realistic, especially if you come from one or more marginalized groups within, if you're looking at your intersectional identity, your ability to affect change may be limited by the way that you are treated. You may not have the microphone as much as you need to. For any of us who have, positions of power, whether that's because we're in leadership or part of our identity or all of our identity aligns with a group that is in the majority, that is given more power, it is up to those of us in those situations to make sure the mic is passed to folks who are underrepresented. And of course, it's tricky and kind of a catch-22 to say, work on institutionalized racism by doing what? What if the institution in which you're in has its own issues that are at the structural level, which they all do? Where is the first place to start? So we don't have all of the answers, but we want to say that just starting to think about these things is important, and really just being able to observe what seems fair, what seems unfair, the places in which we kind of accept this is the way things are here, and instead start saying this is the way things should not be, and starting to have conversations with people who do have power in figuring out how resources can be distributed or redistributed. And the taking too of being patient with yourself, popping that right back at other people who may not be up to speed on things, and using that as an opportunity to educate folks. And of course, to educate yourself rather than putting the burden of being educated on folks from marginalized groups. So there's a lot to think about here, but these are just some places to start. And Anshul, as she has been doing so beautifully throughout this event, dropped this implicit tool right into the chat box if you'd like to click on it further. All right, so looking inward, what does this actually mean? Checking in about your own implicit bias or biases is an ongoing conversation you need to have with yourself. It should be uncomfortable. If you're comfortable, then you're not learning. We want to create a safe space for you to explore this continuously. It's tricky. It's hard to put ourselves out there. It's hard to hold ourselves accountable, but we need to be doing that, and doing that for and with each other. And most importantly, we are in positions of being able to affect major change within the healthcare system. And so the ways that we show up with and for ourselves and each other is only going to further benefit the work you're doing with clinicians, within your teams, and the work that they do, the ripple effect of that with their patients. So we've talked a lot about correcting language and moving forward. That's something that sounds maybe simple to some, maybe too easy. It's very powerful to say, you know what, that's not Susan's name anymore. Her name is Susan, and these are the pronouns that she uses. Things like that can be incredibly impactful. So working together, and again, throwing your hand up and saying, I'm uncomfortable and I don't know what to do, is always okay, versus pretending that you know what to do, which is something I think we force ourselves to do from time to time. All right, so we're going to play a little bit of chat waterfall at the end of the day today. You see a group of teenagers walking down the street, and it is during school hours. What is the first thought that comes to your mind? And pop that in the chat box. Or if you want to put it in quotes as a thought that someone with stigma might think, you can do that as well. So we'll give you a moment there. Elizabeth Ballymock says, why am I not off today too? I love that. I would think that too. Ooh, they're skipping school, Susan says. Jackie says, open campus lunch? That would be amazing. Skipping school, says Carolyn. Is it a PD day, professional development day? Oh, they're delinquents. They're skipping school. Why aren't they in school? Are they really teenagers? I can't tell anymore. Dave, I am right there with you, sadly. I can't tell if someone is 12 or 22. Why is school out today? Where are their parents? Tisk, tisk. Again, so thinking all of these things, and maybe thinking like, oh, maybe they're up to trouble. Who knows? Oh, the youth, Vishal says. All right, so we're having our thoughts. We're just having them. And Nicole, thank you for throwing in something that I haven't heard from anyone under 80. Hooligans. All right. So Anna, over to you for a little change of pace.
Yes, we are going to switch gears and look towards our detailing work. So pretend you're detailing on the topic of obesity, and a clinician says to you, these patients are never going to change. There's not much we can do. What do you think about the clinician? Like, what was the first thing that came to mind? You can type a word or phrase in the chat. Bevan says judgmental. Carolyn, how do you know? They're burned out, uncaring, burnt out, closed-minded, ugh.
Ugh.
Oh boy, this clinician is a little jaded. How can I get them to change their mind? closed-minded. This is going to be a doozy of an AD visit. Patients can't trust them. They haven't taken the time to connect with their patient. Bias, frustration. It insinuates there is something we can do. They say what they think without thinking. This face, the sideways face, jaded, opportunity, anger, honestly. They could be projecting inner struggles onto patients.
Sure.
Mhm.
Yeah, these are all great thoughts and so multifaceted.
And stressed out, losing passion for the job. Tell me about that. As someone who is heavier, what are they thinking of me?
Yep, all
Mhm.
good stuff. All right, next sub question here.
And some of this was answered in the chat, but why do you think the clinician said that?
So we heard burnt out, which is great. And we did hear that maybe they're projecting their own insecurities. What other reasons do you think a clinician would say something like, "Meh, there's nothing we can do about obese patients"?
Brad says apathy, behavior change is hard, lack of education. They have seen their patients not change in the past. Uninformed about obesity, burnout, frustration. So the clinician doesn't have to change. Maybe their years of experience with patients, insanity, doing the same thing over and over and over and expecting change. Lack of knowledge about obesity, lack of compassion, frustration, pressure to move on to the next patient and make money for the clinic. Because
Ooh,
they are trying, oh, that's a huge one. Because they are trying to address a very complex issue in less than 15 minutes with all the other things. And Kendra, sometimes it's less than 15 minutes, as you know. Just like tobacco cessation, it takes a lot of attempts to get there. If they are not the same group as the ones they are talking about, it may be the other phenomenon.
othering, yes.
Needs more education on stages of change and how to help patients move through those stages. And lastly, we have Sarah saying poor communication skills, too many times taking a directive approach versus using motivational interviewing skills.
Love all this, everyone. This is great stuff. All right, Anshul, let's talk about breakout groups and what we're going to get ready to do. And then we are going to give y'all a fun project. We think it's fun. We're biased. We have implicit, very aware bias of how fun we think this is going to be. So bear with us.
All right, so you'll be heading into breakout groups in just a moment, but just a reminder that this is a space for you all to come together, talk about solutions, ideas, come away with some resources, and we do encourage everyone to participate. But if you're having trouble starting the conversation, one thing that we recommend is have people introduce or speak in alphabetical order.
And if you can all put your screens on for the very last time, we promise. If you really can't, we fully understand. But if you can, we'd be grateful just so the people that you meet can see your faces. It's so hard to network these days virtually. So if you get to see each other's faces, that'll be extra helpful for everyone. So thanks so much for that. All right, Anna, let's walk through this case study.
Yes, I'm going to give you the case, and then Bevan is going to talk a little bit more about the discussion questions and what you'll be discussing in your groups. So your detailing team just received funding for an AD campaign on lead poisoning prevention. Leadership would like you to use an inclusive lens throughout the detailing project, specifically when considering the 4 areas below. So we have staffing and training your team, developing materials and key messages, selecting clinics and scheduling your one-to-one visits, and conducting visits and collecting visit data.
All right, so here's what we're going to do. Each team member introduce yourself briefly. Going to choose a scribe or a speaker or 2 if you need someone, a duo to help shoulder the burden. Brainstorm the top 3 things you can do in each subgroup, and we'll make sure you get all of them. If you look over on your chat box, Anshul has dropped them there, and then we can broadcast it as well. If you have any trouble accessing it, let us know. But what you're going to do is brainstorm the top 3 things you can do in each of these sub areas to make sure your project is inclusive. So how can you be inclusive around staffing and training a detailing team, which is more than just detailers, but by the way. So think about epidemiologists, think about evaluators, think about program managers, think about subject matter experts, clinical content experts. Developing materials and key messages. We got a little bit of cheat sheet on that over the past couple of days with folks sharing amazing work on how to make your materials inclusive. So think about some of that stuff. Selecting clinics. What areas are you going to select? What neighborhoods? How are you going to schedule those visits? And how can you do that inclusively? And last but not least, the fourth one, how will you conduct your visits and collect visit data inclusively? Do your best, come up with what you can. When we come back to the main group, I'm going to type up everything you say in real time. We are going to turn it into a document for everyone who could not make it to the summit to share at future meetings and to be on our website. So thank you very much. I think we are ready to rock and roll. And as Elizabeth says, we don't stop the conversation until forced to. I think that's true of many of us. All right, so here we go. I know we've got some scribes in the house. Don't be shy. You can either start popping your stuff in the chat, but I would prefer if you unmuted as we finish up the day. Hear some voices, hear what y'all came up with. So throw your hand up if you want to nominate your group to start off with something. I would love that.
I don't know if you guys can see, but I already did put all of them in the chat.
Oh my goodness. Actually, no, I don't see them.
I don't see it
You can
either,
them.
Susan.
I think
Wait, I think
Yeah,
if
you'll
you
have
put
to
it
cut
in
and
the
paste.
chat
They
while we're
might.
in our breakout room, only the people who are in that breakout room can see it.
Yeah, so pop it right on back into the chat. And in the meantime, who else had someone speak for the group or start writing stuff? So Ryan, who was in your group? Who was your scribe?
I can go ahead and read our note.
Perfect. So let's
Oh.
start with staffing and training. And as Ryan is spitballing and I start filtering in Susan stuff, if you guys have stuff to add to staff and training for inclusivity approaches, let us know. What do you got, Ryan?
All right, we have ensure diversity within the staff. Make sure that the staff reflects the community we are trying to serve. Having folks with lived experience when making key decisions. And then developing materials and key messages. We want to try to focus on children, find key folks and families that are trusted messengers. Getting water from trusted sources. Looking at older housing and culturally appropriate changes. Bringing testing to patients instead of asking them to come in to get tested. And then selecting clinics, finding where lead poisonings are concentrated.
So you want to do clinics near there?
Yeah.
Near that concentration? Yep. What else?
Does somebody else in the group want to cover a few other points? We had some technical difficulties.
Not to worry, it always happens. It always happens. I'm having it happen right now, so not to worry. Who else was in Ryan's group who wants to share?
We have Abby, Christine, or Kevin.
Kevin, what you got?
I was trying to see where we left off.
Christine.
Okay, so we've all worked on this. I just wrote it down so I can finish it up. Focusing on older housing areas and having translated materials in various languages constructed in a culturally appropriate way.
So having materials in various languages. So you're talking about patient facing and clinician facing?
Patient, yeah, both, yes, for sure, both. For patients and providers. In whatever language, because the providers will be able to provide them to their patients. And then conducting visits and collecting data. During visits, tell and ask real world stories in order to include different patient experiences. It's good to share multiple points of view. And then it's good to ask what providers are seeing too. And then while you're there, if your local health department has information, make sure you disseminate the information from your local public health department to the provider, because they can always use those resources.
Perfect. What else do we have? I'm keeping up on what's happening in the chat, and I'm going to make sure we go over everything. So Susan, thanks for dropping more from your group about what you can do to select clinics and schedule visits. So we have targeting each area across the board of socioeconomic status, heat map of clinics within areas where lead is present, which is very similar to Ryan's group saying, looking at that concentration of data about where lead poisoning is and making sure that you're sticking with those. Customizing calls and emails. Would love to hear more about this. Susan's team, what does it mean putting their fingerprint on it?
I think just kind of like speaking, hold on, let me find where my thought process is. So like if you're going to target like a certain clinic, just making sure that you are providing relevant information that reflects their practice. I think that's kind of how it was put.
Versus all practices. Got it.
And to add on to that, it's the priorities, like making sure you're prioritizing what that clinic actually, what's important to them. So what not only that clinician cares about, but what's relevant to their patients. Like what is impacting them day to day.
Okay.
This is Karista. Kendra took notes for us, but I just wanted to say on the choosing the clinics that I actually think it's really important to see if there's a way to at least do like a 1-question screening or something at all places of contact, because
yeah, tell me more about that.
Well, and it's probably going to sound biased no matter how I say it, so I'm just going to talk because you know, as Kendra was mentioning, like in her area they asked, is your house over 100 years old or over a certain years old, and hers was 100 years old, so she said yes, so her son got tested. And I think that's really important, because although we can look at maps of where things are the hottest, that can also go different ways. Does that mean that they're testing more in those areas, or does that mean that there's more actual cases in those areas? And I also feel like any of the topics that we're going to do for academic detailing, they could very easily apply to any number of marginalized communities. And marginalized communities often move around more and are in and out
that's
of
really
different
important.
places. So we were even thinking about like, what about any kind of institutionalization, whether that's a elderly home or a prison or you know, transitional housing for a marginalized person. So it just, I think, yes, once you get past that first question, I don't know a lot about lead poisoning and what all the things involved are, but I know it can come from your pipes. Kendra was mentioning like brownfields with landfill and stuff. So I think it's important to maybe have a sweep campaign to try and get everybody to at least ask that one question. And then if there are other questions that can, like if you say, no, my house isn't old, but there's some other key question, then that might take you down a path to, yes, we can still test this person. But maybe have a more robust program in places where you already know there is a hotspot.
So
Sorry,
it sounds like
I might have said a lot of words.
No, that's great. That's great. It sounds like what you're talking about too is making sure the questions that are being asked to identify the patients and the populations and the areas aren't in and of themselves biased and missing people, or biased and grouping people together, you know, based on stigma. And I think that's really, really important. We have a lot of stuff blown up in the chat. Nicole, you are keeping me on my toes in the best possible way. Materials, ensuring community voices are involved in the development of materials and key messaging, 100%. A lot of folks put that, and I just love how much everything from the past couple of days is just really resonating right now with what's going on. If there are any last minute additions, please pop them in the chat, but otherwise I'm going to go through all the sections, and please ignore any of the typos where I cut and pasted from the chat box. We'll fix those up where there's poor formatting. But okay, so let's say we want to do an inclusive AD campaign, which is exactly what we want to do. We know this is for lead poisoning, but the great thing is, as I'm putting all this stuff down, I'm noticing how much this is relevant to any new campaign you're going to do. If we just pull out the lead poisoning, there's so much stuff here. So let's look at staffing and training. And hopefully I haven't missed anything. If I have, please call me out on it. So making sure the staff itself is diverse. We're looking at everything from the detailers themselves to the epi folks, to program managers, to anyone who is supporting this AD project. And more than just having it be diverse, having it reflect the community that's being served. So making sure the specific subpopulation that y'all are focusing on, whether it's in this pretend lead poisoning campaign, prevention campaign, or a new campaign, you want to make sure the population at the end of this whole mission aligns with the folks doing the work for detailing. This has come up a bunch of times, having folks with lived experience asked about key decisions. Having team building exercises to develop bonds, diversity, equity, and inclusion training. Again, same thing here, making sure a team is reflective of those served unique experiences. Learning about where the risks of lead poisoning are and including people most likely to be affected by these risks. I love that you guys went the extra mile and either knew something about lead poisoning or looked this up. We've got stuff where lead poisoning can be not only in homes, but we've got spices, cosmetics, lead paint, pottery. Really good work here, guys. Also, some home remedies may end up having, unintentionally, of course, having lead poisoning in them. Working with community groups like a restoration advisory board or groups from a more broad geography if unable to find locally. I love that. We have ensuring that solutions are accessible and practical to patients, conducting focus groups. I will pop this down here. Using materials from the CDC and considering your own implicit biases and addressing those right from the beginning. I love that. Developing materials and key messages. We have conducting focus groups, using materials that have already been cleared by groups like the CDC. We've got talking to children, families, and folks who are key messengers. Water from trusted sources, looking at older housing and culturally appropriate changes. I love this one, bring testing to the folks instead of making them come in for the testing. Because if you make them come in for the testing, you're automatically factoring out, unintentionally, of course, the folks who don't have access to transportation, who might not be able to take time off and get their kiddos to be tested. So these are all wonderful thoughts, you guys. Educating on the effects of lead poisoning, assure that community and voices are involved in the development of all of these messages, inclusive language for patients and providers, involving community groups and champions as a resource when relevant, all this great stuff, especially around making sure that there are things translated into the appropriate languages in those different communities. Ensuring adequate compensation of community and patient voices. Y'all have learned a lot this week. I know I have too, about how important it is to treat folks with lived experience as though they have a PhD in their own lives, because everybody knows we do, right? Especially folks who suffer from an undue burden of social determinants of health and carrying those health disparities. Looking at section C, how are we selecting clinics? How are we scheduling one-to-one visits? So many great ideas here, from heat maps to customizing your approach to getting into the clinic, going through public schools and the public library to disseminate materials. That's excellent. You're making sure anyone who has access to public education will have access to education about the risks around their housing. Really great stuff here. And last but certainly not least, the visits themselves and conducting the visit data, asking and telling real world stories, getting to that qualitative data, making sure that providers are hearing multiple points of view and then eliciting their stories, disseminating information from local public health, prioritizing information that's relevant to a clinic's particular patients, conducting practice visits to explore pushback. We have great stuff in the chat too. I'll wrap up with Carolyn saying, go where the need is, do your cold calls, show up with posters and clear tape. Yes, Dave. Provide free or low-cost educational resources and educational materials. For building the team, Alexandria's team says, in areas where an application pool is small, reach out for advice and technical assistance from other institutions, organizations, and community groups. Excellent, excellent work. I'm going to go through this chat box and make sure we haven't missed anything, but you all came up with a really wonderful document to help folks start thinking about ways that you can build a campaign thinking about inclusion, not just as something as an appetizer, something as a side dish, but really from the very beginning and looking through that lens at everything you do. So with that in mind, it is 4:45 Eastern and we are ready to wrap up. Thank you so much for participating in that. Really appreciate all of you so much. All right. Anna, I'm going to turn it over to you to walk us through the final few chunks of our show.
All right. So we are going to add that guide that you all just created to our inclusivity toolkit on our website. So this will be a living resource for all of us. We'll also put it on our Summit Hub. You are all authors of a wonderful new resource that we have for our community.
So here's where it'll be. It's going to be right here on this gorgeous toolkit that Anshul painstakingly created over the past year and a half. So thanks for being new co-authors on some of our materials. Back to you, Anna.
Awesome. I think you got the next slide, Bevan.
Oh, thank you. Moving forward, so we want to make sure we're engaging in the world as inclusively as possible. And by we, I mean all of us on this call and beyond. We are dedicated to being a space where you can continue to grow both professionally and personally. And of course, we want to foster an inclusive environment and a professional field that is bigger than all of us on this call or those of us who come to trainings. It's folks who, if they just start academic detailing 6 months from now, we want them to get in touch with all of us in our field and say, this is a field that is inclusive. This is a field who is really up with what's going on, and hopefully get to a place where we can be leaders in the field based on looking at inclusive approaches to academic detailing. So thank you for your work in helping us all get there. Anna?
All right, we want to wrap up the summit by sharing some resources over here at NaRCAD and some upcoming events. So remember that all of the recordings, the materials, and the slides and the resources that we've created together will be available on the Summit Hub within 1 week. We will not have recordings or the workshops, but you'll be able to access the resources and slides from those presentations.
All right, so here's your Summit Hub. You've seen it. Hopefully you'll take a peek and please share it with your colleagues who couldn't make it. All right, so support from us. Some of you are going to be like, we already have your cell phone numbers. And if you have our cell phone numbers, then, you know, we're the better for it. If you don't yet, maybe you'll get there. Virtual support, phone support, email support. We are here for it all. We are particularly here for one-to-one role play. If you've got somebody on your team who really needs to build some confidence or is having a tough time or just wants to brush up on their skills, please set up a session with us. Over to you, Anshul.
All right, so as you might remember from day one, we'll be adding you all to our NaRCAD mailing list. We share event updates, things that are happening in the field, blog posts, and keep your eyes out. We'll be sending a blast once all the materials are uploaded on our AD Summit Hub, but you can opt out of our mailing list at any time. And next we'll be walking through some resources and events that we have at NaRCAD, but definitely check out our website. We have lots of different toolkits, webinars, community events, so definitely take a peek as well. I'll pass it to Bevan to talk about one of our toolkits.
So the Program Planning Hub is another of Anshul's most gorgeous creations. Everything from building a program to tracking and evaluation is on this toolkit. Please take a look. Tell us what's missing. Tell us what you want us to add. Tell us what your pie in the sky resource would be, and we will start working on it. We love a challenge. So check that out. I'll just drop in everything into the chat box. And now she's going to talk about our best practices blog and some of the cool new stuff that has been posted on there as of late. Anshul.
Sure. So the Details Best Practices blog is something that Anna and I both co-manage. We share stories and best practices from the fields and people working in different academic detailing programs. We also have different types of themes as well within our blog. So you'll see on the right-hand side, there's different varieties of topics that you can look through. But if you're interested in being featured, definitely reach out to us.
Right.
And we have a new podcast on Spotify called Changing Minds, Transformative Talks for Healthcare Improvement. I'm very excited about this podcast. We have 4 episodes so far. We just dropped one, which I'll tell you about in a moment. But we release an episode a month, and they're about 20 minutes long, so they're perfect for a quick ride around town in your car or walk around your neighborhood. So please reach out if you're interested in being featured. And we've been having so much fun covering topics from improv to train the trainer to the impact of academic detailing. And the last one was on harm reduction. I interviewed Emmeline Paintsel from Iowa, and she talks about her project detailing pharmacists for harm reduction. Really, really cool work. Please follow us on Spotify, take a listen. I'd be so happy if you did.
Especially if you subscribe.
Yes.
We love subscriptions, because right now I think Vishal, are you our only ride or die right now?
It might be. I absolutely listen to it while I make drives, and I love it. It makes my drive so much more fun.
Going on a NaRCAD drive, a podcast cruise. All right. Quarterly check-ins, just a few more slides here before we let you go. Can't say enough how much we enjoy these with you all. Please come, invite some newbies, invite some veterans. It's a space to have similar to the roundtable we just did. Solutions sharing, putting your heads together, saying, this is really bugging me. I don't know how to approach this. Or, hey, I really would love to approach it this way. Has anyone heard of this? So please join. It's a very informal space to just have some chats. They happen quarterly, and if we get enough interest, we might do them more than that. So let us know. Anshul's going to talk to you about trainings that are available for either refreshers or new folks on your staff.
All right, so our trainings are another one of our big offerings. We have a training in August, but that is currently full. If you would like to be added to the wait list, please reach out to us. Our next training is in October 1st to 3rd. Registration opens on July 15th at 12 p.m. Eastern. If you're interested or someone on your team is interested, we definitely recommend folks to register the day of or the day after, because the spots fill up super quick. So yeah, definitely keep that on your calendars if you're interested in attending.
And again, please join us November 14th and 15th for our 12th International Conference in Boston. You can join in person or virtually. Registration opens July 15th, so mark your calendars. We hope to see you all there. I was on maternity leave last year, but I will be there this year, and I'm excited to meet many of you in person.
All right. And on behalf of our whole team, I'd love to say thank you to all of our fabulous presenters and partners, with a special thanks to the Agency for Healthcare Research and Quality, who have funded our events series, which includes our conference and our summit. This is only our 2nd summit compared to our 12th conference, so we're about a decade behind, but we're taking baby steps, and we'd love to know exactly what you would like to see for the 3rd annual, what worked, what didn't. So in just a moment, we'll give you 5 minutes to fill out the eval if you would be so kind. We don't have any incentives, and we don't have a paper copy to stand in front of you and wag our fingers, as Jackie has said, is the easier way for her to get survey results from clinicians. But if you would do us a solid and let us know how it went, we'd be so grateful. So thank you so much. Please stay connected with us. We always love to hear how you're doing. And we really do want to feature you on the podcast. So if you have something cool and new that you want to share that's going on for your project or your program, we would really, really love to feature you. So day 2 evals, please tell us how it went. If you didn't get a chance to do day 1, it's all at the same link. The link is going to be in the chat box. Oh, it's right there in the chat box, second to last comment. Narrative feedback is extra great. Tell us if you didn't like something, please just tell us why, and you don't have to leave your name. It can be anonymous. But if you do leave your name, you'll be entered into the $250 raffle. There's one for each day. So you have the opportunity to send $500 to charities that are working on global and national public health initiatives. Thank you guys so much. We will leave this up and we will turn it over to Mike Fisher to say goodbye. And then the rest of our squad will bid you adieu. So Mike.
Thank you all so much for being here, for being part of this community. Thank you to our team, our amazing team. But really, the exciting thing is that we'll get to keep seeing you. So looking forward to seeing you at community events at the conference in November. But for now, hopefully take a chance to reflect on what you've learned and especially what you've brought to the table, which we're very grateful for.
100%. Anna, over to you to wrap us up.
Thank you so much, all of you, for the past 2 days. I feel so lucky to be part of this incredible community and just share space with all of you. Keep doing the terrific work that you're all doing. This is important work and you're all making an impact on your communities. I have so much respect for each and every one of you. So thank you to our attendees, our presenters, our funders. What an absolute pleasure to get to learn and work alongside all of you. Take care, and we'll hopefully see you in November in Boston.
All right. Bye from our whole team. Once you have that eval open, feel free to rock and roll. So great to see y'all. Talk to you
Thanks,
soon.
everyone. Take care.
See you soon. Yay, Nicole. Can't wait to see you in Boston. Woo woo.